Hi, everyone. Welcome to the GHAPP MASLD Community Network. Our topic today is on non-invasive testing. My name is Oyin Penny. I'm a nurse practitioner for Premier Gastroenterology of Kansas City. Please use this QR code to record your attendance for this meeting. And also visit the GHAPP MASLD Community Network to view Madrigal's MASH disease state education and Madrigal Rezdiffra promotional program. So we're going to jump into our case study for today. So to help contextualize this further, we're going to review a typical patient presentation that's been referred for assessment of suspected MASLD. A case study today is Albert, who's a 65-year-old male with obesity who's been referred for elevated liver enzymes and abdominal ultrasound that's remarkable for increased echogenicity. It's consistent with steatosis. Upon review of his labs, his triglycerides 89, his HDL is 41, hemoglobin A1C is 7.2%. It is noted that his ALT has been elevated 1 to 2 times upper limit of normal for the last 3 years. All the other evaluations for chronic liver disease have also been ruled out. We went over his social history with him. His alcohol history is pretty much unremarkable. He said he has not drank alcohol since his 20s. Medical history includes type 2 diabetes, hypertension, and hyperlipidemia. On physical exam, you notice some abdominal adiposity with no stigmata of advanced liver disease. His BMI is 29. So given Albert's workup, the most likely diagnosis is MASLD. And now the question now remains, does he have significant fibrosis or not? So the landscape of non-invasive assessment of liver disease in 2025 is quite broad. We're going to start off by going over imaging biomarkers of liver fat, which is the CAP, and MRI-PDFF. For the sake of the presentation today, we'll be focusing mainly on the non-invasive tests, the NITs, that are highlighted on these slides. CAP is a calculation that you can get on FibroScan to measure the fatty change on the liver, while MRI-PDFF is used to quantify fat on the liver using an MRI. The next subtopic is imaging biomarkers of liver stiffness, and we'll be talking on vibration-controlled transient elastography, which is also known as the FibroScan, and MR elastography. Next is the clinical prediction rules for fibrosis, which is the FIB-4. And then we have the proprietary serum markers for fibrosis, which is the enhanced liver fibrosis, also known as ELF. And finally, the combined rules, which is the FAST. And these are used in combining two tests to determine if a patient is at risk for advanced fibrosis. For instance, FAST is used to assess risk for MASH, which combines FibroScan and AST, and a score greater than 0.67 is usually indicative of high risk for advanced fibrosis. The ME-FIB is a score that combines both the MRE and the FIB-4 to determine progression of liver fibrosis and cirrhosis. And finally is the MAST, which combines the MRI and AST to determine patients with MASLD and MASH who are at risk for disease progression. So let's start off with the FIB-4. This is a simple, accessible NIT that utilizes the AST, ALT, and platelet count values from a routine blood test in combination with the patient's age to assess whether a patient has a high or low probability for advanced fibrosis. Because of its simplicity and accessibility, it's often the first NIT to be applied to patients with MASLD. Next is the proprietary serum marker known as the ELF score, which is a test that measures 3 biomarkers of fibrosis, which are hyaluronic acid, TIMP, and P3NP. It has a good diagnostic accuracy for advanced fibrosis, results ranging between 7.77 and 9.8 are usually consistent with significant fibrosis. I do also want to mention, though, that the higher the ELF score, the higher it increases specificity. So for instance, if a patient has an ELF score of 9, that actually has a 60% specificity and an 85% sensitivity. So it's actually a good, accurate test when it comes to diagnosing advanced fibrosis. So our next slide here is actually going over the different types of elastography that we have. So on the top left corner is your transient elastography. On the top right is the MR elastography and what those images look like. On the bottom left is your point shear wave elastography, and on the bottom right is your 2D shear wave elastography. So since shear wave travels faster through a stiff liver, as stiffness increases with fibrosis, this slide just goes over the various differences between transient elastographies. I do want to mention that both the 2D shear wave elastography and the point shear wave elastography have a high sensitivity and specificity for detecting each stage of liver fibrosis. The main difference, however, is the region of interest. With the point shear wave elastography, you're limited to about 1 by 0.5 centimeter at a time, where with a 2D shear wave elastography, the region of interest, also known as the ROI, is actually wider, about 2 by 2 centimeter. So this allows the operator to modify the size and also obtain real-time colored stiffness maps during these studies. So the vibration control, transient elastography, also that we're familiar with, also known as the FibroScan, gives us 2 measurements. It's a short exam that is non-invasive, usually about 10 minutes, gives us a measurement of the liver stiffness and also the steatosis, correlates with liver steatosis. Both biomarkers can be used to assess disease severity in different etiologies, including MASH. Whenever you're getting a FibroScan on a patient, you do want to make sure that you have 10 valid measurements. You want to make sure that the quality of the image is good. You also want to make sure that your operator, whoever is obtaining this test for you, has a high success rate and actually does this a lot. So I do want to mention that if, for instance, in some offices, they train a wide range of people to do their FibroScans just so that way someone is available all the time to do it. However, the disadvantage of that is that if everyone is doing it a few times, they are not as proficient as someone, 1 or 2 people in an office who do it all the time, because you can kind of get a more reliable, accurate result when you have a couple of really well-trained people in your office or your center doing these FibroScans. You also want to make sure that the IQR median is less than 30%. The IQR is basically a measurement of how consistent the liver stiffness measurements are. Here are some things to consider whenever you're ordering a FibroScan on your patient. You do want to make sure that there's some lab factors, such as if your patient has a high ALT or AST, or they have cholestasis, this can definitely affect the result of their FibroScan. There are also some patient factors. Your patient is supposed to fast 3 to 4 hours prior to getting a FibroScan. If they do not fast for the adequate amount of time, that can definitely affect the results or the accuracy of your elastography. Alcohol use is another thing to keep in mind. If a patient is drinking above the low threshold of alcohol that's recommended, then this may affect their results. So I often ask my patients about their alcohol intake. And if you feel like they're not being forthcoming with that information, you may consider getting a PEth level, just so that way you know that if their PEth level is within normal, and your FibroScan is probably going to be more accurate. Morbid obesity is also something else to consider. If a BMI is greater than 35, then you may want to consider a different way to assess your patient's fibrosis stage, and also rule out ascites and liver masses before scheduling your patient for a FibroScan. Just through a regular ultrasound is sufficient enough. So this brings us to the topic of MR elastography, which is a proprietary software that utilizes share wave technology, which is an acoustic driver that's actually placed on the patient, and it produces images called elastogram that are quantitative, multicolored cross-sectional maps of liver stiffness. There are some considerations to keep in mind, just like a FibroScan when you're doing an MR elastography. BMI is also something to keep in mind. If your BMI of your patient is over 40, then an MRI elastography is not the test for your patient. Iron overload also needs to be considered. So if your patient has a history of iron overload, the overload can decrease the signal intensity, therefore negatively impacting the accuracy and reliability of your MR elastography. So that would probably not be the right way to evaluate your patient's fibrosis. If your patient has a non-MRI compatible implant in them, they cannot have an MRI of any kind. Claustrophobia is also something to consider because this is not a quick test. And if your patient is claustrophobic, sometimes we can get by just giving them some anxiolytics, some anti-anxiety medicine to relax them a little bit to get through it. However, if that does not help, then we need to consider a different method of evaluating them. Hepatic congestion, especially in a patient with right-sided heart failure, is something to keep in mind. If they do have a history of that or have it, then your patient will not be a good candidate for an MR elastography. And finally, insurance determines what tests we ultimately do, because if a patient's insurance does not cover the MR elastography, the other option will be, if the patient absolutely wants it, would be to paying out of pocket. But those are kind of some of the measures or some of the considerations to keep in mind when you're doing an MRE. So this is actually a slide that I like a lot because it compares some of the most common NITs that we just discussed, and includes the recommended cut points to rule in and rule out advanced fibrosis, as well as limitations and strengths of each test. It is a good reference. Actually, I would say it's a great reference to kind of keep front and center whenever you're ordering any of these NITs or when you're interpreting any of the results of it. So if it's something that you would want to have in the future, I'm more than happy to share this information with you. So let's return to our patient, Albert, who is now diagnosed with MASLD, and we need to decide the next test. We need to decide the next steps to assess his liver fibrosis. So now we're going to look at his labs that we've already obtained. As previously discussed, there are clinical decision tools out there to help guide the application of NITs so we can apply the MASLD AGA clinical pathway flowchart to our patient. So far, we know that Albert has MASLD, and MASH given his metabolic risk factors. We have his labs, his ALT is 43, AST is 38 with a platelet of 170. So the next step would be to, according to the pathway, to calculate a FIB-4 to determine, to basically risk stratify him. So his FIB-4 was calculated, it is 2.2, which falls into the indeterminate risk. So when a patient falls into the indeterminate risk, based on this flow chart here, the next thing to do would be to get a liver stiffness measurement. The most common one that we get is a FibroScan. So get a FibroScan and it's 6.7 kPa, which indicates that Albert's actually low risk. So with him being low risk, the new recommendation is that we repeat an NIT in 2 years, unless obviously there's some clinical changes or circumstances that requires that we do it sooner than 2 years. I do want to emphasize that when we have colleagues in primary care, endocrine, GI, of course, and then obesity management, we should have a pretty low threshold for screening these patients with NAFLD with advanced fibrosis. And some of the things to keep in mind is that we want to identify those patients that are at risk, especially those patients with 2 or more metabolic risk factors, diabetes, prediabetes, or if the patient has hypertension or hyperlipidemia, those are some risk factors, obesity. Those are things to keep in mind. If your patient has type 2 diabetes, of course, that is one risk factor too, that should be a red flag. Or if you notice any steatosis on imaging, modality, or elevated ALT. In our practice, basically, what we tend to do is whenever I see a patient now with steatosis on imaging, regardless of age, regardless if they have other metabolic risk factors, I'm right away calculating a FIB-4 in these patients to basically kind of help risk stratify them, and also look at other risk factors, even if do they have steatosis and they're heavy drinkers. Those are things to kind of keep in mind, because if they drink more than the recommended threshold of alcohol and they have steatosis, those patients definitely need a lot of guidance and a lot of education and more intervention sooner than later. So that's something to keep in mind when you're seeing these patients. The next step will be getting a good, accurate history about their alcohol use. After you've calculated a FIB-4 on your patients, you want to make sure that you risk stratify them either to low, if they're indeterminate, get a FibroScan, or if they have high risk. If your patient falls into that moderate risk, definitely they need to be referred for either an MR elastography or a liver biopsy to determine how soon or when next you need to reevaluate them. If their NIT suggests that they just have fatty liver without any significant fibrosis, these patients could be followed in 2 years with an NIT. However, if their patients are considered to have high risk and they still fall within that range of stage fibrosis 2 or fibrosis 3, where they could still be treated with, for instance, resmetirom, then those patients need to be treated either by you or they need to be referred to a hepatologist that's comfortable treating these patients, because we have to be aggressive with managing these patients' fatty liver to basically halt the whole process of fibrosis, because the whole goal is to prevent cirrhosis. So we have to be very proactive when managing this patient. So when it comes to managing case study Albert, Since he is considered low risk, in his situation, we would recommend lifestyle modification through diet and exercise. We want to optimize the treatment or management of his metabolic disease. For instance, he has type 2 diabetes. Could we do better in managing his diabetes? Because we know that these patients often have a high cardiovascular risk with their metabolic syndrome. So it's important that his lipids, hyperlipidemia, hypertension, and then his diabetes is well controlled. And that is the end of this presentation. Thank you.